in our OPD, let's say we see a young man about 20-30 years, and he says, doctor, for the past couple of months I find that urine stream has become slow. And we ask him how slow, and he says, yeah doctor, it's really slow. Now I pass urine in practically in drops. And we say, is there anything else that's happening? And he says, yes doctor, once in a while I find that I have pain while passing urine, I have burning when I pass, and I persist beyond passing urine. We ask them to get a few basic tests done. One of them is a urine examination to find out if he has any infection. Other is a test called uroflowmetry, which will tell us how is the speed. We expect that a young man, let's say a 20-30 year old, should pass urine with a speed of about 30 ml per second with a peak flow. On the other hand, it's very slow. If it's barely 6 ml, 7 ml, it's a flat plateau kind of a flow, then we strongly suspect that they could be having what's called a stricture of the urethra. This is important primarily because stricture is extremely common. It is a huge nuisance. We do not know why it happens in about 80% of patients. Some people say, yes doctor, I remember having had an occasion where I had an injury, I fell down and I injured my genitals. Some people say, doctor, I had a catheter placed earlier and it was pretty bad, I had lot of infection at that time. So these are people who can probably tell us why they had the stricture, but 80% of the time we will not know why it has happened. And it could be a small stricture, it could be a huge long stricture. And the treatment is extremely complex. That entirely would depend on what's the kind of stricture they have. So what we do next, we do what's called a RGU. An RGU, or an ascending retrograde ureterogram or an ascending ureterogram, involves pushing in very gently a contrast dye through the urinary passage and taking the X-rays at that particular moment. This will normally we have an urethra which should be smooth and without any irregularities and without any narrowing. On the other hand, if you find a narrowing, then we look at whether it is a short narrowing or a long narrowing, and is there any other issues? Could there be any extravasation of the contrast at the site? And our treatment will depend on that. A typical example would be a young man who would come with a short segment narrowing. If he's come for the first time and if he has no other issues, then we tell them, yes, you need to be on a regular follow-up, but if you're okay with that, then we will do what's called a optical internal urethrotomy, where through the endoscope we actually cut the stricture without any skin incisions whatsoever, and the urine flow becomes superb within a couple of days. We leave them with the catheter for a couple of days, but after the catheter is removed, the urine flow will be very good. But we tell them, no, you don't be off guard. You need to come on a regular basis. Make sure that the flow is indeed as good as it is earlier. On the other hand, if you find that the flow is coming down, then it basically means that stricture can recur. So that's the major problem with strictures. Strictures tend to heal again by contracting. So you cut open the stricture, you lay it wide open, but because it's human tissue, the tissues tend to come together and you can have a narrowing. So you need to balance it by doing what's called dilatation. Sometimes we teach the patient they can do a dilatation themselves. On the other hand, sometimes the patients say, doctor, I cannot do this dilatation on my own, please help me. And then we tell them to come on a regular basis, maybe once every 3 months or 4 months. And then we do what's called urethral calibration in our OPD. It's a simple process, but they need to follow that. If they don't do it, then they'll again come back to square one where the flow will again be slow. So that should not happen. So optical urethrotomy is a good exercise provided the patient is willing to come back on a regular basis for follow-up. And sometimes we do have young fellows, we do know that they have stricture, but the stricture would be pretty long. And they say, doctor, is there anything I can do? And we say, yes, the optical urethrotomy could have been done had the stricture been smaller, but now you find that it's pretty long. So they say, what else can be done? So then we say that there is an option called Buccal Mucosa graft urethroplasty. This here, what we do is we take the inner lining of the cheek, which is very similar to the urethral mucosa, which is the lining that lines the urinary tract. We take the inner line from the cheek through an extremely simple process without any major cut, so that the appearance of the face does not get disfigured. And through a surgical procedure, we apply it on top of the normal urinary passage. So this passage, which was initially very small, tends to become wide open. But this is an open operation, that in the sense you have a cut and you need to stay in the hospital for about 3-4 days. But the good news is this gives a long-term satisfaction of more than 80 to 90%. And these patients, if let's say if you've just done an optical urethrotomy, the day you remove the catheter, their flow will be good, but within 5 days the flow will again become very narrow, and they will not be able to do a dilatation, and they'll be causing the disease that caused them this trouble. So buccal mucosa graft urethroplasty is an excellent option for long segment strictures. It gives good durable results. The appearance is not at all affected, and the patients do come on a regular basis, probably once every 3 months, just to tell me, doctor, I'm doing great now. Thanks for the help.
Appropriate treatment and procedures are being recommended for surgeries with precision and minimal invasive technology. A patient can recover from the surgery in the shortest time with best results and be back on their feet attending daily routine.